You are listening to Prevention is the New Cure, all things health and NHS with a political twist.
And that's with me, Dr. Helen Stokes-Lampard, and Steve Bryan MP.
Hi, Helen.
Hi, Steve. How you doing?
All right. Nice to see you again. It feels like ages, actually, because we had a bit of a half-term break. But this is episode 24. Wow. And today we got a guest joining us later on. So we're going to talk about preventing harm in the community in A&E departments. So it sounds like an interesting idea. So you'll introduce a bit more of that later. And last time, do you remember we had Victoria Atkins, no less?
I couldn't forget. She was great. We did have a really wide discussion, didn't we?
We did.
We pitched a lot of questions to her. I have to say, I'm quite impressed that she managed to deal with them all. I was still impressed that she managed to remember all the things in the Pharmacy First initiative, all the different diseases. There was a lot of talk. We talked about vaping, all sorts of things. What stood out for you?
Yeah, Pharmacy First, I think, is really important. It's something that I did the trial on when I was the pharmacy minister back in Theresa May's government up in the northeast of England around hypertension. And they've now obviously launched it as of the 31st of January around the 7 conditions. And we actually had Community Pharmacy England in front of the select committee earlier this week, and they were saying, that it's going really, really well. Yeah. There's been tens of thousands of consultations, and really the logical consequence now is to take it into chest infections. So it'd be interesting to see whether that actually happens. And I guess really the proof will be in the pudding, won't it, as to whether general practice see it as a success and feel that they can trust it. And I just wonder, from your point of view as a GP, what are you hearing about Pharmacy First?
Well, it's funny, I was in surgery yesterday. One of my colleagues, the one who was the emergency doctor for the day, was sent out a message to us all, be warned, Pharmacy First, because we're using it actively already and signposting patients actively. And whereas a few of our local pharmacies had been involved in pilots, now suddenly they're all involved. Pharmacy First, if you refer for a urinary tract infection, they're only able to prescribe one type of antibiotic. So don't send patients who've got an allergy to, in our case, nitrofurantoin. So that was, but in a sense, for me, that showed it's working, it's up, and it's becoming business as usual already. And that's the thing with a good idea. It rapidly gets adopted as business as usual. So that was good. And there's obviously little things to iron out. And obviously that's something that could be expanded with pharmacists able to prescribe more than one antibiotic for people who have a known allergy and so on. That's just the logical next steps and evolution of the programme. But our receptionists have just picked it up as is just another one when we're doing the triaging, just another place they can navigate patients to. So yeah,
which is exactly what was meant to happen, because pharmacy is part of primary care. It should be seen as part of primary care. They are trained clinical professionals, and some of them are independent prescribers as well. But here's the rub. Here's what concerns me about it. In the first weekend that Pharmacy First launched, I had to go to a pharmacy in my constituency to get some throat lozenges for my boy. And I was in the queue for probably about 20 minutes or so, which was annoying, but actually not unhelpful, because I was watching, not in a creepy way, just watching, as you do.
Yeah,
and in that 20 minutes that I was there, 3 people came in and tried to redeem their prescription. And the pharmacist said, we don't have that one. There's a national shortage on that particular drug. You need to go and check it out with some other pharmacies to see if they've got it.
Yeah.
There is an alternative that would do the same thing, but I can't give it to you.
Yeah,
you have to go back to the GP for it. So I'm not saying that Pharmacy First won't help the workload in general practice, but medicine shortages could just be the drag weight that replaces some of those people that have come out of general practice going back to you guys asking the prescription for the replacement. Does that make sense?
Totally does. And you absolutely, that's my lived reality, Steve. We spend a vast amount of time frustrating for patients, pharmacists, and for GPs and their teams, with patients ping-ponging between the three. Now, nowadays, we do all prescribing electronically. Virtually nothing gets printed until this situation happens when the pharmacist can't fulfill a prescription. There is a challenge about, we have no way of knowing what's in stock or not as GPs. I mean, you get these national messages that come out, but they're out of date 5 minutes after they're sent. There's nothing live on our electronic patient records that we know. And sometimes you're left wondering, what the heck can I prescribe? What have you got? Now, we used to have a pharmacy based inside our health centre. I frequently would just run down the corridor and stick my head around and say, what have you actually got in stock that I can give? And quick chat with a pharmacist, we'd find an answer. but they've outgrown the space in our surgery because pharmacy first means they need consulting rooms in which to talk to patients, and they've moved out the building. So I've lost that fast access. And I mean, there are 100 permutations of this, but we can do better. There must be some ways of getting live dashboards, what's available, what's suitable alternatives. And we had emergency legislation in during the pandemic, which allowed pharmacists to make appropriate safe substitutions. And I'm intensely frustrated that that's not being used now, when simple things like different dose combinations. So, for example, the 100 milligram tablet isn't available, but they've got 50s. So just give 2 50s then. That's just logical. And pharmacists know it and want to be able to do it, but they're often not allowed to because of the rules.
You were slightly scary then for a minute.
Was I?
thought, my God, yeah, no, just give 250. But here's the concern that some people express, which I don't think is actually borne out by the evidence, is that if you have too much of that independent prescribing and replacement and pharmacists prescribing more than they are at the moment, that there will be an over-prescribing of drugs, and that will hit our antimicrobial resistance. Now, the evidence in other settings in other countries doesn't bear that fear out, but it's a fear that some express.
Yeah, it is a fear. And I mean, you have to be, the only thing about being careful is about pharmacists' interests as business owners and creating work for their own business.
Right.
Once you take that out to it, they are highly trained professionals, they are regulated professionals, and actually, for goodness sake, we need to treat professionals with a certain degree of respect and autonomy, and let them be the professionals they're trained to be, and then come down on them hard if they fail to live up to that professional standard. Yeah. You know, we are the most regulated healthcare system in the world by a very long way. I think we can regulate for this.
So there you go. That's Pharmacy First. I hope it's going to be a success. I think it needs to be. I think it needs to be for the health service and for general practice, but let's see. There's a big publicity campaign that started this week about, you know, there is this new service and there's stuff, adverts online. I don't think that there's enough knowledge of it, though. No. You know, I think if you went out there on Westminster Bridge now and asked people, I'm not sure they would have much knowledge of there being a new service. But anyway, just moving on, off the back of Secretary of State discussion as well, we talked a bit about the old dental plan, didn't we?
Hey, your spidey senses were right. You said that I have a sneaky feeling it's on the way, and there it was. Did it deliver, Steve? Was it what you wanted?
Yes, it may have been a sneaky feeling, or it may have been a little birdie.
Insider knowledge.
Either way, it was published that week, and look, I mean, there's a lot to it. I think it's funding and it's reform. So we're talking about making it easier for overseas dentists to come and work here. We're talking about dental vans for low coverage areas, so rural and coastal areas. We're talking about similar sort of scheme that we have to attract GPs to take partnerships in different areers. Yeah. £20,000 golden handcuffs. That reminds me of someone. General practice. 20 golden handcuffs reminds me of someone I knew at university, but let's not go there.
Another time.
She was fun. Anyway, but the point being is that, you know, the aim is to increase appointment capacities by about 2.5 million extra appointments next year. Yeah. I worry about this because I worry that, it sounds like I always worry, but I do worry because the thing is, there's nothing in here that actually promises any imminent contract reform. And what I said in the House of Commons was, every day that this current units of dental activity contract is in place is a problem. And the British Dental Association have sort of backed me up on that.
Yes, Sarah, as we spoke to a few weeks ago, didn't we, on the podcast, we were talking about this. It was very much a contract reform needs to be at the heart of anything going forward. So what is this, A for effort, but a B plus, B minus?
Yeah, I think it's a B.
Yeah, okay.
I think it's a straight B.
Fair enough. Moving on.
What have you been up to? You got some news for us.
Yeah, so declaring interest in all that stuff. By the time the podcast goes out, it'll be announced that I am now on the board of NHS England. I have joined as a non-executive director starting as of the 19th of February officially. So it's going to be very interesting, bring some different perspectives.
Well done, you. Well, congratulations. That's really great. You'll be working with some really interesting people.
Yeah, it would be nice to be able to bring a primary care perspective to the board.
So, we are going to quite a few things we're quite keen to talk about this week because we also got the guest. Measles.
Yep.
Mobile phones.
Right.
Earwax.
I thought we were going to have 3 M's there, but that was going to be too much. Okay.
Measles.
Yeah, measles. Yeah, well, we've actually had the first confirmed case in our practice now. We thought we'd had a case before, but it wasn't confirmed. But we've now definitely had a case. Do you know, it's amazing how it focuses the minds of people to get their kids and loved ones vaccinated when there's a case in your town. So we've had
Yeah.
to develop a practice protocol for how to do it. Do you know, it brought the whole pandemic stuff flooding back about how we had to, infection prevention control issues in full. But, like everywhere, general practice steps up to ramp up the vaccinations. I know all practices around the country are frantically chasing down anyone on their lists who's not been vaccinated. I mean, everyone gets offered the chance many times, but this is focused minds. It's a nasty illness, really nasty, Steve.
Oh, 100%. Yeah. And just to be clear for those who listen, vaccination, best way to protect you, as you say,
Highly effective.
symptoms, high fever,
Yeah.
which could be lots of things, but blotchy red or brown rash, coughing, sneezing, often sore eyes,
Yeah.
red and
Watery.
watery eyes.
Mm.
Just well worth chalking up those things and keeping a note of them, isn't it? Because, obviously it clears up usually within a week, 10 days,
Yeah.
but can be pretty severe, the complications, can't it?
It really can. I mean, it can be fatal, but you can have sort of types of pneumonia. You can have meningitis with it. It causes blindness. So this is very nasty, totally preventable. But one of the big problems is it is so incredibly infectious, and it's infectious for a very long time before people get symptoms. So that's where one of the challenges had. Anyway, we've got big clusters: Midlands, London, Northwest, Humber. They're expecting clusters elsewhere. So, we have got exactly the problem that's been predicted for the last couple of years, unfortunately.
Should we talk about mobile phones?
Yeah, so you're worried about mobile phones, Steve?
Well, I tell you, the thing is that here's a confession, right? As a
Okay.
parent of two
Uh-huh.
teenagers, I fail every day.
Okay.
And being away at half term, we were on a long car journey. It's obvious more than ever to Susie and I, my wife, that the pull of these devices is incredibly powerful.
Yeah.
And the issue sort of has gone right up the scale in recent weeks since the tragic murder of Brianna Gay.
Yeah.
And her mum is now leading calls for under 16s to no longer be allowed access to a smartphone. I'm sure you've heard it. And there's lots of campaigns going on. There's probably the most high profile campaign is called Stick to Bricks, as in stick to the old Nokia phone, which, is just about makes a call and just about sends a text message.
Yeah.
But those campaigns are really getting noticed. And basically the argument goes that, we don't know, a bit like vaping, we don't know what this addiction, because I suspect in their heart of hearts, our kids know they're addicted to this endless tedious scroll of TikTok and Instagram and the other social media channels. But we don't know, do we, what that is doing to their young brains. Is it, is it rewiring their young brains so they struggle to concentrate on anything for very long?
Well, I mean, I'm sure we could get somebody on to talk about this in due course, and perhaps we should look for somebody who's a bit of an expert in it, because I know I'm not. What I do know is in clinical practice, I see regularly kids, usually teenagers, being brought in very reluctantly by parents who are desperately worried, and the meltdowns that happen if the threat or the reality of taking a phone away is quite something to behold. So you are right, Steve, in that there are a lot of neurological changes coming, that we don't truly understand. I mean, there have always been worries about, kids getting square eyes and watching too much telly. There is always something that is worrying parents about children and their usage. And we also know that mobile phones give them access to a phenomenal amount of information. There are security elements to having a phone. And so these are complex arguments. And the challenge about blanket bans is that I guess they don't give our young people credit for the positive use that they can put to these things. I'm trying to be balanced here. This isn't the BBC.
Well, look, they can, because obviously, there are diabetics who use the smartphone for all sorts of connections. And we're going to come on in a minute, talk about mobile phones in schools, because that's been in the news this week. And, often teachers will ask children to get out their phones to access something, do a bit of research on something, and all of the homework apps are, guess what, on a smartphone. But I guess the point that I'm making just before we get onto that is this sort of dopamine hit that as it's described as the white lights of the phone and the social media, and we don't know the long-term consequences of it. Now we are running a podcast here about prevention. The government spent about 100 million quid in the last 2 years on soaring mental health problems among school pupils.
They are soaring.
I think more than 1 million children each year are referred to CAMS services. Whether they can get into them is another matter, but that's because demand is outstripping supply. And I just wonder whether it's time to be more radical, and other parts of the world are doing so.
So let's move on to the suggestion about mobile phones in schools.
Yeah, so Gillian Keegan, the Education Secretary, has this week made good on a promise that's been kicking around for years, which is that we will, quotes, ban mobile phones in schools, end quotes. Now, in practice, what she means by that is that new guidance has been sent to head teachers. So I spoke to a number of head teachers this week on my patch, and I guess the rubber will hit the road on this one. The moment of truth, if you want to put it that way, is to see whether any of this will actually be any different to what schools are already doing. And speaking to head teachers in my patch, what they mean by ban mobile phones is that they got to stay in their school bag switched off during the school day. Now, does that happen? Well, yeah, for some kids it does, but of course for many not. And, I think we should recognize here that teachers, every bit as much as us parents, are right on the front line here. And it's a really, really difficult situation. But if if some people say we should just ban them completely, so children shouldn't be able to have a mobile phone in school, they should hand them in at the start of the school day and collect them at the end of the school day. But I've got schools where children travel quite a long distance on the bus from Basingstoke down into Winchester, and for them not to have any access to a device at all, I think is probably a safeguarding safety issue. So not to mention the practicalities of schools taking in a phone at the start of the day and then handing it back. You've got teaching.
Who gets the right one back?
Yeah, you've got teaching unions saying don't handle money, don't handle phones, because these are expensive pieces of kit. And if you did have that, would kids just hand in the burner phone and keep their iPhone in their bag, which they then go and use in the toilet at break time? So it's an absolute nightmare.
It's a minefield.
Minefield. I just wonder, is the genie out the bottle, Helen?
I suspect it is, Steve, but I think there are ways of managing. I mean, I think, no use of phones in the classroom. There are ways of doing this that are, I think in a sense, it'll give more power to head teachers' elbows, and that's a good thing. And knowing that there is, guidance that backs them can be helpful for teachers, particularly in areas where these things have not been tackled before. There'll be many areas in many schools where this is already part of the normal culture. And my dad, I don't know if I mentioned, my dad was a head teacher of a large school in South Wales for many years. And I mean, this challenge is post the time that he retired. But there are many times where head teachers feel out on a limb when they're trying to uphold high standards, what they believe to be the morally right and responsible thing to do. There will always be a small group of parents who are vehemently opposed to any change they bring in. And so strong, clear guidance that backs the head teachers in trying to do what the majority think is the right thing, I'm sure would be very welcome.
I'm tempted to say, don't you?
What?
Why don't you just switch off your television set and go and do something less boring instead?
That ages us both.
Which TV series was that, Helen?
That was Why Don't You?
Why Don't You? Exactly. Why don't you switch off your mobile phone and go and do something less boring instead?
Yeah, I know. It's a good line. Very retro, Steve. Very retro.
I know. Most people are just like, what on earth are they on about? Anyway,
okay, moving on. Earwax.
On the subject of earwax, which you're going to raise the subject of earwax. Go on.
Well, I know earwax is one of those very divisive topics. Some people love to talk about earwax as in any other bodily fluids or bodily products. Others detest talking about it. But as a GP, earwax comes into my consulting room very regularly and gets talked about a lot. And I am frustrated that we have such a postcode lottery for earwax management and removal across the country, across the UK. It's not commissioned properly. And I mean, there was a story in the BBC News a couple of weeks ago that about 10 million people in England cannot access free services for earwax removal, which includes in my area, by the way. And the problem with earwax is that, because people laugh about it, but it's a hideously distressing problem, and it messes up people's ability to use hearing aids. And if you can't use your hearing aids properly, you become socially isolated, depressed, and all sorts of challenges ensue. And it is such a treatable, manageable condition that I think we are storing up all sorts of problems for ourselves by not treating it, and we can do so. Any thoughts? So
doing it on the NHS is really, really difficult to find. Asking for a friend, declaring an interest. Because I was just saying to the producers of our podcast earlier, I can't hear what's coming out of the monitor. I can't hear Helen very clearly. And when we were away last week, my ears were definitely blocked, and my wife said, you want to go and get that Hopi ear candle thing, or basically your earwax. And one of our friends who was with us said, "Oh, I went and got my earwax removed," and then he had a photo on his phone of what came out of his ear, and he showed it at dinner. I mean, honestly, Helen, it was, we were there enjoying a burger, and he showed a picture of his
I'd
earwax.
have been interested.
Who does that? But anyway, so I think that I need my ears seeing too.
Okay, well, GP advice, assuming you're not in pain, you're not feverish, it's probably just simple earwax buildup. Get yourself some simple ear drops, olive oil ear drops, sodium bicarbonate
I
drops,
hear you.
3 days of use of one, swap to the other. Make sure when you put them in, you lie on your side for at least 20 minutes on each side, then flip around and do the other ear. Do it twice a day. It takes quite a lot of
Interesting.
discipline, a lot of time.
Yeah, well, Monty, my Labrador, and I both need our ears doing. So
You're probably a lot easier to get Monty sorted than yourself.
yeah, we could have an ear thing together. He went away to see Sharon when we were away last week in half
Oh, he
term.
likes Sharon.
So, yeah, he likes Sharon, and there's a WhatsApp group called Monty's Holly Bags, which is set up with me and the kids and her and Susie on it, and then we get constant pictures of him doing things. And I was slightly jealous at how much he seemed to be enjoying himself. But anyway, he was fine. When I picked him up, he was Dad's dog again. So
okay, well, just don't go and try sorting out Monty's earwax yourself, okay?
Okay.
Dogs, like humans, don't stick small things into
Don't
ears.
stick things in your ears. I once put a bit of Lego up my nose when I was a kid.
Have
you ever had that in? We should ask our guest. I wonder if you ever had that in the surgery. Someone come in with a bit of Lego up their nose.
I stuck a peanut up my nose when I was little.
Yeah. Well, I suppose there are probably worse places that you could stick things.
There are indeed.
Little boys.
I did end up in A&E getting a nut removed.
Yeah. Okay. Let's take a break, and then you're going to introduce our guest.
I am delighted to welcome a friend and a colleague to the podcast, Steve. I'd like you to meet Dr. Adrian Boyle, who's a consultant in emergency medicine at Cambridge University Hospitals Trust and president of the Royal College of Emergency Medicine. So, Adrian, it's a huge welcome from me. And I think Steve wants to say hello because you've met before, haven't you?
We have met before. Adrian, this is a less formal setting than last time I saw you, which is when you're sitting in front of my select committee giving evidence, which sounds terribly like you're in court, but you're not. But anyway, welcome to the podcast. Great to see you.
Yeah, great to be here.
So, Adrian, you and I started chatting about some awesome work you've been doing, and we'd like to pick up on that in a second. But I think the first thing we wanted to check on you is that are you feeling okay? You've recently had quite a nasty cycling accident. Are you properly on the mend?
Yeah, I'm getting better. So a month ago, I fell off my bike. I broke my hip, and I had personal and lived experience of being a emergency medicine patient in my own department. So it was slightly surreal, but I've been operated on and I'm getting better, but it's a slow process, but it does create a bit of time to do fun stuff like this.
Well, it's a pleasure to have you here, but that's definitely not the reason why we would have wanted you to be on the podcast. I'm interested in that being on the other side experience thing. I know we need to get on to the important stuff that you want to talk about in a second. Sharing the experience, learning points for your colleagues, for the rest of us?
Yeah, so it's interesting. I've been thinking about what does it change the way I see the problems in emergency care, and I don't think it does. It sort of reinforces that an ambulance delay, and there was an ambulance delay for me, is actually really distressing, not just for the patients, but actually the bystanders around you. And that was quite something. We were initially told it was going to be 2 hours before an ambulance could get to me. I'm sitting there on the side of the pavement with a broken hip in sub-zero temperatures, and by the time the ambulance picked me up, I was hypothermic and shivering.
Oh my gosh.
And then when I arrive at the hospital, I'm told I'm the 12th in the queue to be offloaded into the department. And you can see, actually, it was fine. No harm was going to come to me. It was just going to be a bit tedious and a bit painful. But actually, if I'd been seriously injured with something significant, that could have been a bit of a problem.
Oh, if you had those comorbidities, I mean, I have to say, hypothermia in the back of an ambulance is no joy as a start. So, knowing you're bleeding into your hip as well. Anyway,
Adrian, is your bike okay?
Steve?
Well, it's slightly scuffed on the back, but if anybody wants to buy bikes, I've got a whole selection of bikes in my garage now for sale because I'm slightly salty about cycling at the moment.
Don't get Steve started.
See, I'm worried about the bike, Helen. You know how I worry.
I know how you are.
Do you know what? We've got a children's hospice in Winchester, in my constituency, called Naomi House and Jack's Place, and they have got this recycle bike hub, which has raised £50,000, right? So what you do is you take a bike in there, and they will then recycle it and sell it for the hospice. So if you've got bikes to get rid of, Adrian, I know just the people. Naomi House Hospice down in Winchester. It might be a bit far for you, but
good plug.
let me know.
Right.
Carry on.
Adrian, tell us about the awesome things you're doing with data in A&E. Tell me what's been going on.
Okay, so as an emergency doctor, we tend not to think very much about prevention, and I know that's the key theme of this, but there are actually things that emergency departments can do to promote good health. And I've been involved with a program that I do in my own hospital and a number of other hospitals do around trying to reduce violent crime in our communities. So the intervention, and it was initially trialled in Cardiff, so where you come from, is that when a patient with an assault turns up, the receptionists ask them 3 key questions, in addition to all the usual stuff that they ask them. When did the assault occur? Where did the assault occur? And whether a weapon was used.
Okay.
Doesn't take very long to ask those 3 questions, and quite often patients will tell you this automatically. They say, I was outside the dog and duck and I got hit over the head with a brick. Yeah. And that is the information. How long did that happen? Oh, about 20 minutes ago. That's sort of information.
Yeah.
Each month, this information, and there's a lot of assaults that go into emergency departments, gets collated, shared in an anonymous aggregate form with the Community Safety Partnership. Now, the Community Safety Partnership comprises police, local authority, fire and rescue, and all the people who are actually charged with trying to reduce violence in a community. And then they know they've got additional evidence around where hotspots are. Because one of the things underlying this is, of all the people who go to emergency departments after an assault, only about 25% of them are ever actually known to the police in any form. There's a big...
Oh, really?
Yeah. And you can imagine it's less likely if it's a domestic assault.
Yeah.
There's lots of unrecorded crime. So even if the police were absolutely perfect at identifying perpetrators, arresting people, there'd still be a lot of violent crime representing to health. And we see this time and time again. There's all sorts of studies that have shown that the vast majority of violent crime victims who go to healthcare are not recorded by the police. And it's never gone over 25%.
Wow. That's really interesting. And so certainly in general practice, we see a lot of domestic violence stuff. The sort of people who won't go to A&E or turn up, sort of weeks later with deformed fingers or resolving hematomas and so on, and are adamant that they won't let us involve the police. And unless, of course, there's a safeguarding issue, we tend to respect their confidentiality. So we know there's an issue there. But this is obviously about more violent stuff. Steve, what's this raising for you?
So where exactly does this happen? Presumably it's more your Cardiffs, your Londons, your Manchesters than it is your Winchesters, or am I wrong?
So England and Wales, there's about 300,000 assault victims who go to emergency departments each year. And you're right, it is the places with the big nighttime economy. A lot of this is actually related to deprivation. You're much more likely to be assaulted and require hospital treatment if you live in a deprived area. And it's that's the where. It's also the who. It's mainly young men, and it's also mainly men between the ages of about 15 to 30. It's that age group.
Yeah. So you said that you send aggregated and confidential data. So this isn't breaching anyone's confidentiality. You're collecting the data a bit like Cluedo style. Blokes, dog and duck with bats and bricks or whatever, or knives, or presumably you can pick up things like clusters of knife incidents.
Yeah, so people get very excited about knife crime. Knife crime is highly clustered in a few key areas where it is a huge problem. So it tends to be the big urban areas, and we're talking the big city centres. So, very obviously in the Londons, the Manchesters, and the Liverpools, it's very, very clustered.
Okay.
The vast majority of assaults that go to emergency departments across the UK are nothing to do with knife crime.
Okay.
So in my own hospital, we see about 600 to 700 assaults a year, of which there are probably less than 20 stabbings.
Okay.
So what this is an intelligence gathering operation, isn't it? But it feels to me like, is there a role for the dreaded, excited AI here? In that, is this not a computer program tool where you feed in information and it looks for patterns, which is one of the benefits that AI can bring and saves that human time? Because what we don't want to do we, is find your staff in emergency departments distracted from their clinical responsibilities.
Yeah, so I mean, think about AI as a way of just handling data well and doing clever things with data. What this depends on is somebody collecting that data in the first place. So let me give you some examples of how this data gets used. So in my local patch, we identified that there was a problem near a homeless shelter. And this came along at the same time that a local supermarket, and I'm not going to name names because that's probably unhelpful for your podcast, but every little bit helps, wanted to start selling alcohol 24 hours a day opposite a homeless shelter. The police initially objected. The supermarket then put in an appeal, and I was called to give evidence and say, how many assaults have you seen near the homeless shelter? And we gave them data. And we said, look, there's about 50 assaults a year. We also augmented this with ambulance data and the police. And it was the appeal was thrown out. That supermarket is not allowed to sell alcohol next to a homeless shelter. It seems like an obvious thing that you should try and stop. But actually, the idea of all these homeless people, many of them got massive substance misuse problems, having access to alcohol at 3 o'clock in the morning didn't fill anyone with enthusiasm.
What do the police think of this?
So the police find it useful because what you do is you also tell them about areas that they don't know. Most police are a little bit wary of it because you find them another area that they might have to respond to. You also give them evidence which they can use in licensing appeals to augment their own data. And they can say, oh, yes, we've had this number of police call outs to this place and this number of assaults come to this place, which gives them a strong case to turn down a licensing application.
I mean, I think this is great. So how widespread is it, Adrian? I think you implied this, because Steve was implying we should put this into AI and do it nationally. I think you were suggesting it was not yet a national thing. Yeah,
so the implementation is difficult. So we've been, I've been banging my head against getting people to do this for the last 20 years. At one stage, under the coalition commitment, there was a coalition commitment to get this to work. And we got to a state where we thought about 60% of emergency departments across the country were doing this well.
Okay.
It has drifted a bit, partly because there's no incentive for people to do it.
Yeah.
And it is different business. Some people actually find it quite hard to do, and it requires a little bit of local leadership and maintenance to it. We do it really well in my local place because the receptionists really buy into it, and it's actually they've been given the reason to do it and they can see the benefit. And a lot of them, they're middle-aged women, they have teenage sons who go out and go drinking in the city centre, so they're very invested in trying to keep the city centre safe.
So is that
cool? Well done, you. I mean, what else could? It's obviously, we're all about prevention, right? And we're all prevention sort of upstream. This is less upstream, isn't it? But I mean, what else can EDs do then to prevent violent injury turning up on the floor of your emergency department?
Well, I think there's a whole bunch of things. So this is very targeted against nighttime economy and nighttime violence. I think there are absolutely things that we can be doing to prevent subsequent violence. And that's actually around having pathways and referral pathways for people who are running into trouble. And that may be things like child safeguarding, and having good responses to children who turn up, who are getting into trouble. And I think there's absolutely this first thing that a society needs to do is look after people well for their first 1,000 days. And Andrea Leadsom did a really good piece of work with the paediatricians about how you bring up children well for the first 1,000 days. But there's also a bit trying to head people off when they're sort of getting into a bit of trouble, age 13 to 15, before they go to the bad.
Yeah.
Pathways, again, around domestic abuse for women who present initially to emergency departments and disclose abuse, having a pathway to refer somebody on to what's called a domestic violence advocate or support service. I think that's also helpful in reducing further attacks.
And then just picking up on that one, Adrian, sort of, I bring it back to the primary care perspective. Domestic violence is always one that I struggle with because it's always, for me, it's incredibly hard to get them to go to the police, involve the police. And I do wonder if there's something, have you got examples of where there's sort of good primary, secondary care collaborations in these sort of things? Because I've heard that some good ones exist. I just haven't seen or experienced one.
So I have I think the police have a marginal and difficult role with domestic abuse.
Yeah.
The greatest things that we can do around helping victims of domestic abuse are not necessarily criminal justice based. And actually, there's a high end where people need non-molestation orders, and they also need to know that a dangerous man is going to be locked up.
Yeah.
But there's a lower level of advocacy and support, which I think is probably more helpful for more people. And I think having the ability to refer on, that is a much better thing.
Because there's a lot of this about soft intelligence. I mean, I know we're going off into a slight tangent now, Steve, but there's a lot of stuff there. Do you see, I mean, I'm not sure this is as much of a thing out in leafy Cambridge. Am I allowed to say that? No judgments about lovely Cambridge here. But, you know, I work partly at the University of Birmingham, and obviously inner city Birmingham, there's always the challenge about honour-based violence. Do you see anything of that? Is there any role here?
So I think that those are good questions. They're important questions. This particular intervention that we talked about, the receptionist recording data, that wouldn't help with that.
No.
And it also wouldn't help with things like FGM, female genital mutilation, which again is also important. But remember, this is people disclosing the information to a receptionist, usually in front of a queue and an open waiting room. Yeah. So, you know, it's a specific, different intervention. There's a whole bunch of things that you need to help people with different important problems like that. But this intervention I'm describing, this isn't going to help with that.
So can we do anything to help you get to 100% uptake of this, Adrian? What would work? What do you need?
So there are bits of legislation, and you know, I'm looking at Steve now, which have helped with this. So the Serious Violence Duty came out last year, and that places an obligation on local authorities to work together to reduce violence. Clearly, key to this is actually, I think, engaging health in violence prevention a bit more, because I think it's something that most health people don't think is that important, and they look at the patient in front of them, but don't think about the bigger picture.
Yeah. Thank you, Steve. Any last questions before we let Adrian?
Well, no, I think it's great, and I mean, look, you know, we talked with the select committee with you before. Obviously, there's all sorts of workforce challenges and workload challenges, and I just wonder, you know, what impacts it having on morale among staff. What I like about this is that, you know, it's not just sitting there saying we need more staff, we need more money. It's saying that what can we do in our communities to try and reduce demand on our service, and that's what we're all about, is reducing demand.
And I love the bit that you engaged the receptionists who've taken ownership of this and they feel they're doing something meaningful, a small bit of extra, which has real meaning in their local community. I really like that angle. Yeah.
And, you know, if we got this working in every department, we could save 60,000 attendances for violent injury across England.
Very good.
Year.
That's a lot of people, saved a lot of hassle. It's a lot of people who remain economically viable while they're not having to recover from injury too. So... Adrian, it's been absolutely fab having you on the podcast. Thank you so much for sharing this with us. Please take care of yourself and do recover well. Be a good patient. And look forward to seeing you soon.
It's been an absolute joy. Thank you.
Thanks for coming on. See you soon. Cheers, Adrian.
Bye.
Well, that was interesting, wasn't it? Adrian telling us about what's going on in emergency departments with his crutches. We could see his crutches on the screen, couldn't we?
He was waving them, yeah. I put a feel for him. That was a nasty accident. I think he was downplaying what he told us. I think he's had a nasty time.
I think so too. But anyway, the bike's okay as well.
Well, that's a relief for you.
Notice I was worried about the bike as well as Adrian's leg.
He took that very well.
Anyway, pod surgery is back, so let's hear this. Go on, what have you got, Helen?
Well, I think we haven't got a lot of time, Steve, but I've just got a medical curiosity to a bit of a you heard it here first story. How familiar are you with Alaskapox?
Is this some kind of pox, like a smallpox?
Yeah, it's a pox family. It's another one of the pox families. You've heard of mpox, what we used to call monkeypox. We've got cowpox and smallpox and so on. So a new pox virus was picked up. It was actually first identified in 2015. There've only been 7 cases ever. But the reason I bring it to you now is that the first person has died of Alaskapox. Now, all the cases have been in Alaska, but this is one of these viruses, like the other viruses in this family, that will jump from humans to animals. And this is where it's come from. We haven't yet had human-to-human transmission confirmed, but that's obviously what everyone's getting concerned about. And I think it's a public information. Anybody going on holiday to Canada, you need to be aware of Alaskapox so you can prevent infection.
Okay, right. Well, but would I have to be in Alaska for this?
Yes, you would. Are you planning to go there anytime soon?
It's not on the agenda, but I mean, you never know.
You travel a lot.
Select committee's off to Sweden soon.
Oh, that's nice.
So,
Well, if you get in practice, will you avoid interacting with small mammals, please, when you're on your travels?
I'll
Because
make
that's where Alaskapox comes from.
I will make a mental note. So look, loads of things going on in politics and health at the moment, as always. We on the select committee, we just kicked off this new thing called leadership in the NHS.
Good.
Which has garnered so much interest already, and we've not really started it. So people want more information on that. If you just Google Health Select Committee, House of Commons, you'll see what that's all about. So we're looking at what good leadership looks like in, ICBs, in trusts, in GP surgeries, and I might point out at NHS England. So it'll be interesting. And Amanda Pritchard, obviously Chief Executive of NHS England, is aware of this and really keen to engage with it. So
yeah, sure she is.
Credit to her, who I think is a very good thing. So anyway, that's it. That's where we are. We're done for this week. If you want to get in touch with us, podcast@stevebryan.com will reach us. Thank you for those who have. If you want to find us on social media, you can search Prevention is the New Cure. And we will be back in a couple of weeks.
Take care. Bye-bye.
Thanks. Bye.